This is her 6th-year position, serving Senator Law Professor and a father, and a child, somebody with all kinds of care. And so, these that I hope here are that I'm familiar with and that I experience personally, and don't simply look at from this. The idea for these healthcare reforms arose last spring when discussions with my fellow senators like Denny Jacobs, and to add, by the way, I don't know of anybody who's an effective advocate for their communities than Denny Jacobs for this area. In discussions with some of my Democratic colleagues, one of the things that we became aware of is that there was a strong likelihood that we would potentially be in control next year. As many of you know, over the last 8-10 years, Pate Phillip has been president of the Senate. Many of our initiatives in healthcare arena have been bottled up. It looked like we're now going to have an opportunity to actually move some important legislation forward. At the same time, we're in a situation we're going to be suffering from significant fiscal constraints. Many of you read that the state budget not significantly improved this year over last year. It may be that we have some additional cuts that we're going to have to make. And so my thought is that it's absolutely vital for us, if we want to make significant press on the healthcare front, to go around the state, listen to people, find what their top priorities are, what the issues are to make the biggest difference in their day-to-day lives, and make sure that those priorities are reflected in our agenda when we present legislation next year. So thus far, we've already had 3. This is actually the 3rd of such forums that we're hosting. We already had one in Peoria. We had one in Palatine, the northwest suburbs of Chicago. We're going to be having hearings downstate, Decatur, Alton, and areas like that, so that by the time that we're completed with this process, we hope to have had at least 8, maybe 10 hearings. We're transcribing, we're tape recording the statements that are made, and use this to formulate the kinds of agenda, the sorts of legislation that I think can really make a difference over the long haul. Now, a couple of things that I want to say about what we've already heard. Number one, a lot of people are concerned right now immediately about the West Nile virus. And I think we'll have some testimony from our public health official locally to talk about the concern there. As Denny mentioned, we've already introduced legislation that's going to introduce some addition, that's going to appropriate some additional money to the local health department to deal with the West Nile issue. I tend to think of this as an immediate crisis, but part of a broader problem, and that is how we think about public health issues and prevention. And one of the things that we've heard throughout the state is that public health departments don't have as much money as they need to provide the preventative care that actually over the long term can help us save money. If we invest wisely in prenatal care, we make sure that children are actually getting to dentists, we make sure that they've got eyeglasses, we can prevent a lot of the long-term illnesses and health problems that they may have. So that's something generally that we've heard. The second thing, obviously, we've heard a lot about is prescription drug coverage. I'm sure that that's something we'll hear about here tonight. We've also heard a lot from local institutions, hospitals, healthcare facilities, and so on, about Medicaid reimbursements, labor shortages, and finally, we've heard a lot about the problem of long-term care. Many people are trying to deal with how they're going to be able to either long-term care with parents or themselves. And I'm sorry, we're hearing a lot, simply the extraordinarily high costs of just getting insurance generally, the large numbers of people who are uninsured either because their employers don't provide it or because the premiums are so high. And for those who are members of unions, we've heard specific from unions about the amount of time is now taken up with negotiating health benefits as opposed to wages, because both unions and employers have to deal with the escalating cost of care. Now, not all the problems are going to be solved tonight. We're going to expect the testimony to be brief, questions and answers. We hope everybody is asking a question or making a statement. I got a number of experts here. We've got several representatives actually from Lane F. office who can talk about some federal issues that Denny and myself may not be as familiar with. So I hope you use this as a resource forward to listening. This is as much talking as I'm going to do for the and before I turn to our first witness, I want to thank IBEW for making this wonderful hall and facility. I also want to thank Neil, who's sitting in the back, and my staff person, Showman, for helping to make this job. So, with that, let me move on to the first person who's going to be testifying. And again, the format right now is we're going to hear from some testimony of people who know what they're talking about in some specific areas. And we're going to hold all the questions until that testimony is completed. We've got 5 or 6 people who are going to be testifying. So the first half hour, we're going to be spending time listening to the experts. The second half hour, we're going to be spending time listening to you. If that works with everybody, then the first person that we'd like to hear from is Mr. Martin Tinberg, who's the Health Administrator of Rock Island County Health Department. And he's going to just give you a brief update on the West Nile virus, because I know that's something that's on the minds of people locally. It turns out that just in this immediate area, we've had 3, I guess, reported cases very recently. So this is some very timely information that you can get, and as soon as we get that out of the way, we can move into some of the longer-term issues. Mr. Tinberg.
Is this on now? Yep. Yeah, okay. I first of all want to thank the senators for supporting Western Nile, and I think this is one of the better pieces of news we've heard so far in the public health community, just as a way of getting some dimensions in it. In 1917, Illinois had an outbreak of malaria, which is, again, caused by mosquito-borne. Right now, the Western Nile virus outbreak in Illinois is the second most prevalent outbreak we've had from mosquitoes now in the history of Illinois, the first one being malaria. We're not done with it yet. Right now, I think as of October 1st, there was nearly 600 cases of Western Nile throughout the state, plus additional maybe close to 50 individuals now have died from it. The most closest death in the area is Knox County, where an older individual died from it. But this is just the tip of the iceberg. There's probably individuals now been infected with the Western Nile virus, but because they were healthy enough or had good insurance, got to the doctor, various things like that, they didn't develop the disease. This is a disease that right now is affecting the old and the very young. And those are the people who are getting it. Now, Illinois, there's no real reason we can pinpoint why we are having this type of outbreak. We were thinking that other places in the south, in the east, would have more of a problem, but Illinois is definitely having, probably would end up one of the worst cases of outbreak in the country. Now, I think in our particular area, right now we've had, one case in Rock Island County with other cases in the surrounding counties, but we're also seeing a number of dead birds. We're also seeing a number of, can you hear me okay? Okay. A number of dead birds. We're also getting reports of dead horses recently. This affects mammals and in a lot of different ways. Having a dead horse, real recently shows that the mosquito virus is still in the area. We talked about some special funding from the state health department. What I proposed to them, because we have some unique geography, as everybody knows in this area, you try to go from Rock Island to East Moline, you run into what we call ravines. You can't get there from here sometimes. Well, each one of those ravines may have small pockets of water that need manpower to get into those pockets of water and determine if there's presence of the mosquito larvae in those, and if present, maybe start larviciding and things like that. What I proposed to the state health department was something like that, because at this point in time, with the temperatures dropping, they're thinking the mosquito activity is not going to be as bad, but I'm thinking more about next year. We can't predict right now why Illinois is getting the number of cases it's getting, but we do know that we got to be prepared for next year also. And I also want to speak that we do support the special appropriation, because there's a double-edged sword here right now how the state is funding its existing West Nile control efforts is taking money from local health departments and redistributing that to other areas of the state where there's a high number of cases. What that means to us specifically is a loss of $58,000 in funds that in an area where we really do fund our disease control efforts. Now, for some of you, who, seen media reports, we had a case of rabies in a nearby county in Iowa. That, person died from it. He died from before he could tell anybody about what his activities were. There was reason to believe he was in Rock Island County during some of that time. We're dedicating efforts to find that out, to help determine whether or not the infected bat was here or not. Well, that's how we use that money that we're going to lose next spring, because the state health department said that we have to deal with this crisis. They're going to, want to support looking for special appropriations that the senators are proposing. And I think that, I know that the public health community will welcome that and welcome the leadership. I don't want to start thinking about how a loss of nearly $60,000 is going to impact our department next spring, because I'm counting that the taxpayers will understand this, the Senate leadership will understand this, the House leadership will understand this, and the governor's office will understand this. We need this type of funding for two things. One, we can deal with the current crisis, but as Senator indicated, we can also deal with the people coming into our offices every day for other issues. It's important to the public health community, and I appreciate the time that you allowed me to speak. Thank you.
Thank you very much, Mr. Tinberg. Okay, next we've got Ms. Suzanne Golden, who's a Rock Island community leader.
Not a professional. My professional boss back there, Gary Weinstein from Transitions, is probably one who should be speaking here. I'm a volunteer of about 20 years with that agency, Transitions for Mental Health, formerly known as Alliance for the Mentally Ill. I have mental illness in my family. I think anybody who knows me knows that I don't suffer from depression, but I will tell you that you can hardly pick up a newspaper or turn on the television today that you don't hear a story or read an article about depression. And I'm particularly concerned with depression among seniors and the medications that they need. I'm going to look at some notes here simply because I don't want to give you any information that I can't substantiate. Many seniors take medications for depression, and they take medications, probably the cheaper kind, because they can afford them, particularly if they have other complaints or illnesses. And if it comes down to whether they can afford the depression medication or the medication that's going to make their arthritis feel better, I don't have to tell you which med they're going to buy and which one they're not going to buy. You have to know that when they can afford their medications, they take the one that will fix the pain, but seniors without benefits are sometimes more apt to take the inappropriate ones, and untreated major depression is the best predictor of heart attack and death within 12 months after cardiac catheterization. I don't know if you know that. Untreated major depression is an independent risk for death within 6 months after a heart attack. People with untreated depression after a stroke are 3.5 times more likely to die during the 10-year period after stroke than those with treated depression or those with no depression at all. If they can't buy the medications that are prescribed, they might turn to this. There goes the mine. Okay? I'm sure that many of you, I try to do visual aids. This says you can save on your prescription drugs, and it says that Congress has made it possible for us to get these huge savings, but you have to send by mail to Canada to get drugs. Now, I take, which I'm sure is not of any importance to you at all, but just to bring it down to this, I take 8 prescription drugs every day. Now, I'm a pretty healthy person. My drugs, my prescription drugs, and I have the printout at the drugstore to prove it, cost me $4,000 last year. I'm very fortunate. I do not have prescription insurance, but somehow I managed to do that without choosing between this and food. But that isn't true of many, many people. I don't understand, Senator, why we have to go to Canada in order to afford it. And I figured out, for 3 of my meds, in 2 months, if I go to Canada to find them, I will save $1,400 on those 3 in a year. And those aren't the most expensive ones. I have a daughter who has a mental illness. She's on SSI. She's an old daughter, because I'm an old person. But if it weren't for that, she's co-pays for her meds. I can't do that, and I know a lot of you can't do that. And it seems just unbelievable to me that let me read you from Trinity's latest bulletin. The new Canadian mail order component, introduced in July, provides increased savings on name brand medications. For more information, call Trinity. This is a disgrace for this country to have to, I don't know, somebody told me there was a bus going to Canada. You have to get on a bus and go to Canada to get prescriptions that you can afford. That just seems incredible to me. The administration, our current administration, federal administration, is proposing deep reductions in Medicare payments for a wide range of drugs and medical devices for elderly and disabled folks. Hospitals won't be paid enough for certain services, and they have to stop offering them. I think I've used up my time, Senator. Thank you very much for letting me address what I think is a very important. And we're all going to go.
Thank you very much. And we may bring you back for an encore during the question and answer period. That actually is a pretty good segue, though, to Phil Hare, somebody I suspect that all of you know, district representative for Congressman Lane Evans. I've heard terrific things about the work that Phil does, and I know that this is an issue that he's very passionate about and has been keeping abreast of in Washington, the whole issue of prescription drugs, and he may be able to comment not only on Sue's issues with respect to new legislation allowing purchases from Canada, but also what we're going to be doing to make sure that folks don't have to take the bus. So, Phil?
Sue Golden was a very tough act to follow.
Today. And it's just appalling, some of the things that happen to these residents. And that's my position as being an advocate for residents. I go in and investigate complaints, and I try to make the quality of life better for those residents. Sometimes it's real difficult when there isn't enough staff to advocate certain things for residents when you know that the staff isn't there. So that's a big concern of the Ombudsman program throughout the state of Illinois, and we're so glad that you're here today. Thank you.
Of the 3 hearings that we've done so far, the witnesses have been by far the best behaved in terms of keeping on time. I don't know if that says anything about Rock Island, but it's very much appreciated because by staying on time, it's going to give everybody an opportunity to speak. We've got 2 more witnesses. Linda Long Fainter, is she here?
I not only work with American Indian veterans, which Vince was also talking about. My dad is an 82nd Airborne World War II veteran, and he was in Quincy And because my sister's son has MD, and he's had I don't know how many surgeries, he also had a rod put in his spine. Young people with MD don't live past probably 24 years old. Not only that, because the gas prices were going up, my sister and I were concerned about, we didn't want my dad to feel like we just dumped him at the Quincy Veterans Home. And let's see, all of us have sugar diabetes, which is really out of control with a lot of cultures lately. And that's very expensive, especially if you're a child who has sugar diabetes. Now, some of us control it by diet and some control it by pills or by insulin. I just had a friend who had a liver transplant and he's also got sugar diabetes. So when we're talking about health care, I'm also in a union, Illinois Education Association, and they negotiated our contract for our benefits and everything, but I did have a $100 deductible, and now it's up to $250. So I'm kind of spread out everywhere. So, and my girlfriend said, "You don't have a normal life, do you?" And I said, "No, I don't." So they said, keep it at 5 minutes, and those are the things that are affecting a lot of people. So when the gas prices were going up, we asked for help from the Veterans Administration to move my dad from Quincy to the Missouri Veterans Home, because the Missouri Veterans Home was like 20 minutes from my sister in Columbia, Missouri. And so we weren't getting any help for 2 years, and finally I went to Lane Evans' office and he said, "Have you gotten anything from us in the mail?" I said, "No, I haven't." And so this went on for 2 years, and I said, "This is a man who's a veteran who should not have to stay in this one, where it will make it more convenient and easier on all of us," because my sister kept thinking, what if something happens to me? What if something happens to my husband? Then her 16-year-old son is going to have to go into a state-funded, not hospital, but nursing home, because he is paralyzed. And even if there's a hurricane that comes up, he's afraid he's not going to be able to get to safety because he can't even get out of his bed. So those are the things that are affecting a lot of us.
Okay, thank you
That's
very
all I
much.
want to say.
Deb Katsunis, healthcare nurse.
Over the course of that time, I've seen many changes occur with insurance, with billing, also with the healthcare needs in our population right here in the Quad City area. In our own family, I have a child that at 18 months was diagnosed with diabetes. She's 27, facing a kidney transplant. She has a 4-year-old son that was a premature infant with respiratory distress syndrome, so he has chronic asthma. They were fortunate at the time to be under insurance. It was a local HMO, which is a profit insurance company, as all of them are. And because of repeated hospitalizations for the infant and with her renal disease, the HMO sent a letter and said they would no longer pay for certain medications, and if they would continue taking him into the emergency room, they would no longer pay for that. Myself, as a nurse, I'm also uninsured. I left the hospital to go back to home care, and they offered no insurance. So right now I'm walking on the edge because I also have chronic illness. But my main point is, with the changes with healthcare and the billing procedures, most of the patients I see are elderly, and I see them throughout the Rock Island and Henry County areas. And in the last several years, with the continual decreasing in what Medicare and Medicaid are paying, services are being cut, as you've heard many, many times. And I won't keep belaboring a dead horse about, the costs of medical needs and the costs of drugs. And I guess my final comment is in that we all need to work together and really, if we can't get a national health plan going, at least state by state, looking out for the people that are paying the taxes, for the youth, because they're going to be the next people that are going to pay taxes and, build our economy, but for the people that also are ending their lives. And I'll end it with one comment that a patient who is 83 years old said to me the other day when she showed me her medical bills and her prescription bills, which were $570 for 1 month. Gee, does this mean that the government wants us to lay down and die and get out of the way? Because nobody's helping us. And that's where we're at.
You want this one?
Yeah.
Oh, terrific. We've actually got Jim Reynolds, who's the chairman of Local 1304, UAW, who's going to be speaking to us, and he's not an official testifier. This is actually our first comment.
Yeah,
But,
first comment. Actually, you increased my title a little bit. I'm only chairman of the retirees now. I retired several years ago. I represent a group of retirees who are about 1,400 strong. Right now, we've got a situation that affects about 600 of those people at my plant, and another large group who retired from the Rock Island plant and the Bettendorf plant. We retired with the understanding that we were going to have lifetime health care benefits. And I retired myself in '93 with that same understanding. And things went along pretty well for several years. And then there was a situation where the company rolled out on its own, and our health care cost rolled to another company, El Paso, who we'd never ever worked for, never been there, don't know where it's at even, other than it's in Houston somewhere. And the health care costs started going up. Now, we had a guarantee of free health care. What ended up happening was, to make a long story short, we were told about a month ago, I guess, that we were going to have to pay a $290 a month premium, which was pretty heavy for some people who thought they had health care for life. Today I was at a meeting of about 90 retirees, and we were told that as of January 1st, that's going to go up to $500. And nobody can afford those kind of things. And, you know, we talk about national health care, and that's good. But I think the other thing we have to look at is holding these companies responsible, who most of us gave 30, 40 years of our life to, and who had the promise of health care for life, and now all of a sudden they can kind of run away from us and tell us all of a sudden that our health care benefits are with a company that we never ever saw. The plant that I worked at is still there running the same product they ran while I worked there, with the same management, and all the co-workers that are there are people that I worked with over the years. But I have to pay $500 a month for insurance, and everybody knows what's going to happen. You know, at some point, I can't pay. Other people can't pay, and then the company's off the hook completely. I'd just like to leave you with this one thought. I had a woman come up to me a couple of days ago, and this was before she knew it was going to be $500, and she said, "Jim, can I borrow $20 from you?" And she was about 80 years old. And I said, "Well, sure. I mean, what do you need?" So I was digging around. I'm not sure I had $20, but I was digging around trying to find it. And finally I said, "Well, what do you need $20 for?" She said, "Well, if I can get $20 from you and I take my husband's whole pension check, I can pay for my insurance this month." And I'll just leave you with that. Thank you.
Okay. Thank you very much, Mr. Reynolds. You know what I'd like to do, if you don't mind, I'd like to have Phil and Martin come up, because there may be some questions that are directed either at federal issues or local county issues. I don't want this information gathering. We may not have all the answers for every question that you pose. The important thing from our perspective is that we get the question, we can then go back, have our staffs help with doing some research to find out the answers, and then get back to you. So just right off the bat, for example, Mr. Reynolds, the issue you raised in terms of accountability of corporations, my suspicion is that because most of these are national or multinational corporations, that for us to pass legislation dealing with accountability is probably going to have to happen at the federal level. I know that your experience is not unique, because a lot of corporations are using shell games and lawyers to get out of existing liabilities, even though, as you said, the plant is still there up and running. I don't know, Phil, whether you're familiar with anything that's been going on at the federal level, but one of the things we'll try to do is research and see what kinds of initiatives may have already been put in place to hold these companies accountable. My assumption is that some of it's contractual. You guys had contracts. You should be able to uphold those contracts in court. At the same time, I suspect that there's some government regulation of this area that's allowing these corporations to slip through these loopholes, and I think that's something we're going to have to research. I don't know, Phil, if you've got any sense of this issue.
Well, there's been some talk in Congress about what we're hearing a lot about with corporate responsibility, particularly with Enron and some of the other things that have been going on. On this particular issue, though, you know, to be candid, the Congress has been pretty wrapped up and distracted from our perspective on what we consider non-domestic issues. So I think this is something we need to talk about, and I'd be happy to work with you, Jim, and see. I know we have sponsored, you know, legislation before. Quite frankly, it's going to be tough to get it through the current makeup of the House, as you know. But I think it's something that we have to continually work on, and I think it's something we have to, the story that you told us, something we have to continually talk about every day to our neighbors and to our friends, because this is not the only, you know, company that this is happening to, the one that you retired from, so that we can get it. And when we reintroduce legislation in the next session, hopefully with a different majority, as I mentioned earlier, you know, maybe we've got a fighting chance that we can get some people to come and to testify and to talk to members of Congress about what they're facing. I didn't know until you just told me, that, for example, that it went up $500. I know we've gotten a lot of calls from your retirees on the $290. So thank you for telling me we're going to get more tomorrow after the $500. But that's unconscionable. They expected it and they should have got it. So, you know, we'll be happy to do whatever we can to work with you on it.
Next up, any questions or comments? Yes, ma'am, please. And why don't you introduce yourself so that we all get a chance to.
Okay, I'm Sandy Stevenson. And I have an issue in all respect for senior citizens, but I think there is another level that gets fallen through the cracks. And this is the younger generation. I have a daughter who has a disease, and she is student teaching right now, but you don't get paid. And she's in college. She is still on my husband's insurance, but they just dropped her off prescription. Well, she was taking a prescription for this disease, and due to the fact that the doctor, or the medication that is being used is considered for male pattern baldness, they refuse to pay her.
Is this an HMO?
No, this is, matter of fact, it was IBW. It was the couple here, and with their insurance, they refused to pay it, because actually, the medication is considered for male pattern baldness, but that's not what she has. She has a hair loss disease. And they're using it as, well, we're not going to pay it because that's what it's supposed to be used for. Well, where do you pass the legislation for? There's a lot of people out there who have alopecia areata. I don't know if anybody's familiar with it. And it's very stressful. She's a 23-year-old girl who has had this ever since she's been a year and a half old, and we've been denied prescriptions for her. And now, she was just dropped off. My husband's, he moved up, he's in the international now, so he does have a different plan, but they totally dropped her prescriptions because of her age as 23. But yet she's student teaching, no income. So I see both sides, that the younger generation do fall through the cracks too, because then they come out of college and then they got the college loans, and it's gonna take her a little bit to get a job, to get it. She's gonna need this medication for the rest of her life. So I guess that's an issue that I was trying to get across, that maybe is there something we can do for the younger generation also?
Well, thank you very much for the comment. My immediate response, I guess, is you're raising two issues.
Yes.
One is that young people are disproportionately uninsured. And particularly that's, you know, when they're in college and or immediately after graduation from college. They no longer have their parents' coverage, but they haven't yet secured the kind of job that's going to provide them the coverage they need. So that's a classic group that typically takes a lot of risk. They figure, you know, we're not going to get sick that much, so let's go without insurance. But of course, they're one car accident away from having some severe problems. My suspicion is that we don't get to that group without some form of national health care program. Because by nature, the kind of employment that they get typically is not the kind of employment that's going to provide them with the sort of full coverage they need. The second issue sounds to me like an issue that's typical of HMOs, which is a denial of coverage for a certain prescription drug because they consider the ailment that the patient is suffering from not appropriate for that drug. And they're making some decisions, some bureaucrat is making a decision arbitrarily based on some sheet or some list that they're looking at. Now, we've done a lot of work, and Danny's been one of the leaders on this in terms of HMO reform at the state level. Under existing state law, they've got to give you some pretty good reasons for it, and you're supposed to be able to appeal it. I would have to know the specifics of the HMO process and sort of look at the record to see how effective that appeal process was. It's supposed to be an independent review, as opposed to somebody internal to the company that's reviewing whether that denial of coverage or not. So I'll be happy to get you the details of that legislation to make sure that they followed what they were supposed to do. It sounds to me here that you may just have a situation where even the independent experts haven't caught up with the fact that there are a large number of people who actually can use this medicine beyond folks who happen to be going bald. So, Penny, you don't use this medicine, do you? Okay. We'll make a note and try to get you the copy of the regulations governing denials of prescription drugs, and we'll see if they abided by what what they were supposed to do.
And just to follow up on what Barack is indicating, I know there are a number of cases to where if you fight them hard enough, on some of the issues, they'll bend. But then there's others, hair loss, I don't know if they'll figure that's,
We already fought it and we lost it.
Well,
But again, as Barack indicated, it's whether or not they followed the proper procedures. Did they have an outside independent arbitrator give you that decision, or was it?
The
just
decision
that
was
company?
the appeal board, which consisted of trustees on the insurance. It was the people who handle the insurance for the local, and their lawyer, and then and the contractors.
right.
All.
See,
That's the only process we've gone through.
That sounds to me like an internal process, and I think that what I'd like to do is see if we can find out whether that abides by the laws that are in place right now, which may require or give you the possibility of appeal outside of that process.
Well, this is going to become more common because there's drugs out there today that are being used for different diseases and so forth.
A lot of
And you're going to come up with that same scenario that she had. They're looking at it when it first came out,
Right.
not what has been developed since.
That's exactly right. This is going to be an ongoing issue, but that's part of why we have to have independent reviews of this procedure. Now, keep in mind that there's the other side of the coin, which is a lot of these drug companies have been pushing drugs that the FDA has not approved yet for particular uses, simply because they think it's going to be profitable. So, for example, the FDA has approved a drug, testosterone therapy for certain problems that men may experience as they get older. But now some drug companies are marketing this as, you want to improve your virility, you want to kind of get a little pep in your step, and so they'll market these drugs. In some of those situations, it may be appropriate to deny coverage for those ailments, in part because we don't know whether they work or not. But what you want to have is, you want to make sure that you have an independent outside group that's making those evaluations based on the best current science available.
I wonder why we can't get legislation that would require insurance companies to pay for treatment that is prescribed by a doctor that's licensed in our state, that we would consider them competent enough to be a licensed physician. Why the insurance companies wouldn't be required to just pay for the treatment they're prescribing?
Well, we have been pushing on this issue very hard, and the existing laws have made significant improvements over. The biggest part of the problem on HMOs in terms of denials of coverage was happening 3 or 4 years ago, where they were just denying everything, just on a cost savings basis. As a consequence of legislation at the state level, for the most part, and because, and I think Phil will confirm this, the problem you had in the House was essentially that the bills that were being put forward were often blocked by Tom DeLay and some of the other Republican leadership, but I'm more familiar with what we did at the House level. We eliminated a lot of the power of the bureaucracies to deny coverage on certain illnesses. But you're right that our long-term goal should be that if a doctor is licensed and he has a relationship with that patient and he prescribes a certain drug that is going to be effective for that treatment, given the judgment of that doctor, that should be sufficient for coverage. Now, the HMOs are going to argue that, well, the whole point of us being you joining an HMO is to keep costs down. And if we just let doctors prescribe anything, then we're going to have to hike your premiums up. That's the argument. Of course, when you look at the profits that many of these HMOs were making, what that then tells you is that it had less to do with cost savings that were ultimately going to benefit you as a consumer and more to do with the kinds of profit margins that they were starting to build up and maintain. Which is why actually a lot of folks aren't going through HMOs anymore. It turns out that the cost savings really didn't exist. Oftentimes it was going to their profit margins. But we're not where we should be at, which is sort of describing the sort of environment that I think all of us would like to see. And that's something that we're going to have to continue pushing. Yes, ma'am.
I'd like to know why it is that a lot of us that make very low incomes and my cousin, she's worked for 39 years as a nurse, and she has a lot of medications. I'll let her tell you how many, and so on, and yet, you know, there's not no help for them out there. Yet we pay for all of the rich people, presidents, ex-presidents, senators, congresses, all of their medical bills and everything else. And I think it's horrible that we work. I've never been lazy. I'll work today if you give me a job and put me there. But it just makes me upset to think, because she's younger than me. I'm 75, so what happens, what happens. But there's a lot of young children even that is going, not my children, but a lot of younger children, and I do have some in my family too. And there's a lot of veterans and things for Fred and Vince over here who has helped a lot of people that I know have. And there's no way they can turn to. There's nobody that cares. Lane Evans has been sick, so now I think he knows too just what it's like for some of us, although he's got the finances, he can go ahead and pay for it. And I'm lucky enough now that I happen to have a doctor that will help me. I've got one medication that's coming up, it's $149 a month, but he's gonna try to get some of it help.
I don't think that it's a matter of whether anyone cares. I think it's a matter of cost. Everything we do in relationship to all of the comments that are made here tonight, there's a direct cost with that. As we addressed earlier, the state of Illinois is probably looking at a $2 billion deficit next year. Whereas this year we increased our pharmaceuticals for those on the relief programs in the state by around $130 million. Can we continue to afford that when we're looking at a $2 billion deficit? Do we take it away from education? Do we take it away from health care? The state itself, as you talk about the rich cats, of which our insurance is considered to be part of, the state of Illinois is currently $300 million behind on paying the bills that all of the people in the state of Illinois accumulate. So I don't really think it's a matter that people don't care. I know that Lane Evans cares, I know that Brock cares, I know that I care, and I know of very few in the legislature that really do not care. There may be a few because there's some rascals out there. But I think it really just boils down to priorities around the dollars and how do we do it in order to generate a fair program and for a fair amount of dollars that doesn't just take away money from other programs. And it's really, really very difficult. In fact, I had to really take notice whenever they were talking about the dental program. So many of us forget about how important the dental program is, and particularly young people. It affects not only their physical health, it affects their mental health. We don't have a dental program in Illinois for shit, excuse me. But I mean, really
What'd you
don't.
say? Was that transcribed?
And that's unfortunate, and just as it's unfortunate we can't do a lot of these other programs. All we can do, and that's one thing I have to give Barack Obama just the utmost credit for. It's a real joy to sit in our caucus. And a caucus, for those of you that don't know, is when we as a party in our Senate, we sit together and we talk about the problems. And Barack is a tremendous, tremendous spokesman. And even though, as I indicated in a press release I put out, that even though we're looking at this budget deficit, I have the utmost faith in this guy, that he is going to work diligently to ensure that most of the needs of our people are taken care of in the area of health care, because he just doesn't want to die. And so it's not a matter of caring, I think it's a matter of finances, and that's unfortunate.
How can
Let-
we
let- let-
give
let-
Johnson more raises every year? Why do
Who
we
does
break
that?
it up?
Let me respond to a couple points, because I think Denny raised several good points. I will agree with you on this, that the fact of the matter is that state senators, state reps, congressmen, elected officials generally have health care plans through the government that provides them coverage. That's the bottom line. And the fact that many of our constituents don't have coverage raises some significant questions. Now, Denny is also right that all of us, I think, at least on the Democratic side, would like to see coverage for everybody, and it is going to cost money. Although the fact of the matter is, in terms of what we've seen so far, there's probably enough in the system, there's enough money in terms of spending per capita already to provide basic coverage for everybody. If you put together all the money that's spent on healthcare, it's a multi-billion-dollar industry in this country. And there's enough money in the system to provide basic coverage. But the problem is that we have a system that's developed over time that is disorganized, right? So we have some people who have the best of care, and if they get a pimple on their face, they can go and get laser surgery on it. And then there are other people who can't get just basic prescription drugs that they require to live on, and you have this mismatch. The other thing that you have is a lot of different institutional interests involved. You have hospitals, you have doctors, you have HMOs and insurance companies, as well as patients, and all those different folks don't always have the same, they're not always working in the same direction. So politically, it's often difficult to craft legislation that would, for example, provide everybody with coverage, but doesn't maybe hurt the bottom line of somebody. Right? I mean, for example, the insurance companies generally are going to resist a national health insurance plan because you wouldn't then need private insurance, right? I mean, if everybody here was covered under a national plan, then you would not, I mean, you might still get some supplemental coverage for certain extras that you might need, but generally that's going to cut into the profits of the insurance companies. If you set up a prescription drug program that drive down costs and margins, well, that hurts the drug companies. And so they then are going to lobby and exert their influence on the political process. I think if we get organized and those patients working in tandem with organizations like unions and others, churches that are representative of people, are working together effectively, then at least we can serve as sort of a counterbalance to some of those larger interests. And I think that's what we really need to do. Two things I did want to mention though real quick. Number one, if you don't qualify for Medicare because you work and you make income that's a little bit too high. But you don't have insurance either on the job and simply can't afford private insurance. A program already exists that everybody here should be familiar with called Kid Care that makes sure that your children can get coverage, assuming that your income is at a certain level. Anybody who has children or know people who have kids who are not currently covered because the parents don't have insurance through their jobs, but you think might qualify for Kid Care, you should contact Denny's office, you can contact my office, I'm sure even Lane's office or the Public Health Department. Any of us can put you in touch with those persons at the state level who can sign you up for Kid Care. That's important. The second thing we're doing is we just got a federal waiver, I'm sure thanks to help from people like Lane Evans, that is going to allow us to provide coverage for the parents of children who qualify for Kid Care. So that's going to add some additional persons who currently don't have coverage. They're working, but they don't make enough money and they don't have coverage on the job. They're going to be receiving coverage. What we're trying to do is kind of incrementally, slowly build more and more coverage for more and more of the uninsured. But these programs were all initiated when the budgets were looking a little bit better than they are right now. And one of the things that I know that, for example, the federal waiver that was given to expand to family care is being contested by some senators and congressmen who said, hey, hold on a second, we said we were going to cover kids, who said we were going to cover adults. Of course, if you've got a kid who's sick, a parent who's sick, and you're treating the kid, but every time the kid comes home, parents coughing and wheezing, and, you know, that doesn't make much sense either. But, so there are going to be more budget constraints coming up. We're going to be...
Senator, if I could just say one thing about, I wanted to agree with Senator Jacobs in terms of the issue of caring. I think, to be honest with you, I think a lot of it's priorities in terms of how different legislators look at things. But let me just suggest this to everybody here tonight. I think this has been one of the best kept secrets in terms of, we've talked a lot about this. And I'm not here to necessarily tell you whether, you know, it's a good idea or a bad idea, but there's a price tag to everything. I understand the figures. If the United States were to proceed against Iraq, would run this country between $7 to $9 billion, that's with a B, dollars per month. Now, the administration is saying they think if they do this, they could get this done in about 6 months. Well, my math tells me on the low side that's $42 billion. The point is, we've already gone into the Social Security Trust Fund. We've talked about baby boomers and all that. We're working off of a deficit, and so we are having a very difficult time trying to find the funds to pay for some of the programs that we have, much less expand them. So my strong suggestion to you tonight, and thanks again to these two great gentlemen for being here to even have this forum about it. Because we haven't had a forum on health care around here for, I think, about 1.5 years, Senator. But every night we're inundated on the news with topics other than what we're discussing this evening. And we need to move this to the forefront. And I would suggest ways to do that is to write letters to the editor, call some of your legislators, write a letter to them. A lot of you, a letter means an awful lot, and start putting these issues so that politicians will, once again, if you will, elected officials, if you will start looking at their priorities. It isn't a question, I don't think, that the Republicans on their side of the aisle care, although I would sometimes wonder, but I honestly think they have their priorities messed up. I don't think that they see this as the biggest, as a big problem. To be honest, and one final comment, these people that don't have health insurance, it isn't like they don't use it. If you talk to a lot of the hospitals, Senator, they're going to the emergency rooms. It is the most expensive type of treatment you can get. If you talk to an ER nurse, she will tell you they're seeing patients that ought not to be coming to the ER. But it's that way of doing it. So what we're really doing by not providing health insurance is we are our own worst enemies. And making sure that people have insurance so that they don't have to go to the emergency room where it's about 4 times what it would normally be. So it's really sort of a double-edged sword, and we lose both ways on it. So I'm just saying, in terms of the money, we have to be able to start looking at how we're going to spend it and where we're going to, and what we're going to spend it on, because there's only so much unless you raise taxes, and quite frankly, the American people today are not in the mood for doing it.
We were scheduled to be